सेशन लाइव है। ओके, नहीं दिख रहा है इसलिए। So we'll start the session, students. Okay. INICET respiratory medicine. There were many questions, and they were basic levels. Testing year, clinical application. Start the session, students. The testing year, clinical application, and most are previous year topics. Only few were out of syllabus, but most are stock questions only. The first question, according to goal guidelines, which of the following appropriate steps in management of COPD exacerbation? So this we have discussed many times in our class. In COPD exacerbation, definitely we give systemic steroids to decrease that ongoing inflammatory response. Then we give antibiotics because COPD exacerbation can happen due to bacterial infections such as Haemophilus influenza and Streptococcus pneumonia. And to fight that airflow limitation, nebulized bronchodilators are given. So you should choose an option containing A, C, D. Even though COPD can be exacerbated by viral infections, but they are common seasonal flus such as your rhinovirus or any metapneumovirus. For that, you may not require to give clinically relevant antivirals. So is this the question, students? I want you to tell me in the chat box. Was this a question? Given COPD exacerbation, what to be done? Definitely antibiotic, bronchodilator, steroid. And if they have given what to do in COPD exacerbation initially is NIV. If patient not improving or not fit for NIV, you go for invasive mechanical ventilation. Then I got a recall from few students that there was a question on pulmonary arterial hypertension. We have discussed all the prostacyclins. So we have IV, ipoprostenol, inhaled iloprost, and prostacyclin agonist, selexipag. So which of the following does not work on prostacyclin pathway? Was a question, as somebody was saying. I think the answer would be any one apart from this. Now what about this Dr. Kathi Adhikari? Was there a question like this? Which of the following works on prostacyclin path? Other drugs such as Riociguat or your bosentan, ambrisentan, they work on different pathway. Then which of the following? This is the stock question that I generally tell you in your class to make sure you never get that confusion. See, for anion gap to increase, there should be some acid to be added. One of the reason for acid addition in your body is ketoacidosis. It can be alcoholic ketoacidosis, diabetic ketoacidosis, or starvation ketoacidosis. Whereas the severe vomiting generally causes metabolic alkalosis, and whenever metabolic alkalosis is suspected, we generally don't consider anion gap because high anion gap is significant for your metabolic acidosis. So option containing A and B are correct. Okay, I'll just, was there a question? Yes. It was bosentan does not act on prostacyclin pathway. It is an endothelin receptor antagonist. Then common question, again previous year topic. Diarrhea was another option. Diarrhea, as discussed in our class, this is not having any addition of acid. It is just a direct loss of bicarbonate. You expect normal anion gap metabolic acidosis. Diarrhea is characterized by normal anion gap metabolic acidosis. TB, HIV, always the mnemonic. ATT. Always. It's not just anti-tubercular treatment. It is always the treatment. After that, you can go for ART. The time duration ranges from 2 weeks to 2 months, especially whenever there is CNS TB. We delay ART because already CNS TB is characterized by a lot of inflammation such as meningitis. If at all an iris develops, it will be very, very dangerous. So to reduce the chances of immune reconstitution inflammatory syndrome, we make sure first ATT is started. Within 2 weeks to 2 months, we give ART. The 2 weeks, 2 months in the sense, it can be 8 weeks. Yes, always the treatment. ATT is not just anti-tubercular treatment, it is always the treatment. Then was a question asked in these lines, students, there was a lesion in the lung apex, X-ray was given, and patient classical presentation, there was a ptosis and some weakness in hand. All this suggestive of a Pancoast syndrome. Whenever it is Pancoast tumor, the first suspicion, it has to be a lung malignancy. A tumor or a growth or a lesion in the lung apex which is infiltrating surrounding structures in the neck, stellate ganglion, posteriorly nerve root C8, T1, T2. So for malignancy, what is the gold standard? It is always biopsy. Any option that shows biopsy should be the right answer. Sputum microscopy, if it was an infection, it would have higher yield. Ultrasound, if there was fluid, definitely yes. MRI in lung, not routinely used for common diagnosis. In Pancoast tumor, MRI might be helpful, but it is not diagnostic of a Pancoast tumor. It is just a suggestive for evaluation. Best answer is CT guided biopsy. Was a question given on this lines? Yes. Okay. Dolutegravir was also given in ART question. Yes, because TB treatment has rifampicin. It might cause the metabolism of dolutegravir. We give double dosing. Double dosing. This was discussed in your TB HIV module. Okay. Thank you so much, Dr. Kriti Adhikari. Then, was the question the same wording, Dr. Kriti Adhikari? Because this, I feel, is a bouncer question that has been asked in your paper. According to gold guidelines, what is the approximate cutoff value in FEV1 associated with hypoxemia? See, we have verified the gold guidelines and I have been following the gold guidelines for the last many years. What they say is you cannot predict hypoxemia with FEV1 values. Is the first thing they say. Just by seeing patient FEV1, don't expect patient to be so hypoxemic. Always go by your clinical detection. So go by examining the patient saturation. Was this the question? Yes. Was this the question? How much FEV1 is it FEV1 for hypoxemia or FEV1 for pulmonary hypertension or FEV1 for hypercapnia? For hypoxemia, there is no proper cutoff value anywhere. There was one study done. They have mentioned a post bronchodilator FEV1 of 36% is the cutoff point to predict both hypoxemic and hypercapnic respiratory failure in a patient with COPD. But this is not definitive, and they have told these values could be considered. They did not say they should be considered. They could be considered. Okay. Maybe if it was taken from this study, then it was FEV1 less than 30% cutoff value of a post bronchodilator FEV1 36%. So if they say 40%, I don't think that will be the answer. Then it has to be 30%. Okay. Or what was the option given? Was it like less than 30% or less than 40%? This I want, because if they say FEV1 40%, it does not fall in this range of 36%. If they say FEV1 less than 30%, okay, this can be included. What was given? If they have told FEV1 less than 40, then this can be taken as the answer. So just try to remember the option. And this was a statement given in your Harrison. See, they mentioned that to call it as an hypercapnia and COPD, patient's FEV1, only if it falls less than 25%, it may occur. So here is the confusion. I don't think for your level, they will trouble you much. Maybe they were asking you direct values. If it is direct values, FEV1 40% will not qualify. FEV1 less than 30% will qualify. Okay. So no less than 40%. No less than, okay, it was a direct value. So according to direct value, if FEV1 is 40, I think it is less likely. FEV1 30 is more likely, because 36 they are saying. So anything less than 36 is 30. You can take it. Then RA with ILD features. Can anybody give me the description of the question? Because it is a clinical scenario based question. Many students were unable to give the correct options to this. Was there any CT scan given? Was it a GGO? If it is GGO, you can think of NSIP. Was there any honeycombing? If it was honeycombing, it can be your UIP. Or was there any drug history and it was showing some traction bronchiectasis, anything like this? What was that? Were they asking you to identify it to be NSIP or UIP or any drug-induced ILD, any drug-induced ILD or drug-induced fibrosis, anything like that? No specific finding is given. Everything was mixed. There was mixing of ground glass, traction, honeycombing. Were they asking you to identify, was there any drug-related fibrosis in this patient? Okay, image was given. In that image, what was the finding approximately? Can you make out what was the finding? Was it looking like mild haziness or cystic honeycomb like? Honeycombing is seen. Okay, the true statement regarding the clinical stem is honeycombing is seen. RA is okay. If it was like this with the RA-ILD, if it is RA-ILD, definitely RA-ILD is prone to UIP. RA-ILD, because it is prone to UIP, there can be honeycombing. But we need to know what is the image showing? What is the image showing? Okay, if it is honeycombing, then UIP honeycombing, and in treatment, you can consider antifibrotics. Was it given? Lung transplant, anything on? Do you need to refer this patient to lung transplant, or do you need to start any antifibrotic, anything in that lines? Kindly try to memorize, students. If you are unable to memorize now, don't worry. You can send it to my mail ID and it will be helpful for all our students. Then, what was this question on invasive pulmonary aspergillosis? We know that invasive pulmonary aspergillosis is a pneumonia in immunocompromised. And especially in our body, neutrophils are responsible for clearing the fungal filaments, fungal hyphae. And I think, was this given? Which of the following is the most profound risk factor? Most profound risk factor is profound neutropenia. The second thing is patient on long-term immunosuppressive therapy. Was this the question? Okay. Yes. These were the questions that I could get in recall from many students. 8 questions is a very good number in INICET. And I feel 7 out of 8 you can do it. Except this question, I'm also not very much confident how many students could actually guess this, because it is not there actually in gold guidelines to say when do you call it as clinically relevant hypoxemia, because most of the classical guidelines mention that FEV1 is just a parameter to appreciate patient's lung function, but it cannot say when will he develop hypoxemia. Okay, Dr. Aditi Hora, it was neutropenia. Yes. When they ask you regarding invasive pulmonary aspergillosis, neutropenia has to be in the list. Number 1. Was there any question on any other part here in respiratory medicine? So if you can remember, kindly students, this is my mail ID. bharath.svmc@gmail.com. You can just send your mail here. Okay. So anything that you wish to tell students? So any more things that you want to share? Because I want everybody to be perfect in these topics. You can expect the same questions in upcoming NEET exam also. Yes, Dr. Rahul Chawda, one more question regarding classification, which is false. Okay, one more question on gold guidelines. Can you just tell me in gold guidelines what was the question asked? Was it on ABE classification, or was it solely based on FEV1? When do you call it as mild, moderate, severe, very severe COPD? If you can just let me know, you can type it here or you can send to my mail ID. I'll be very glad to make sure the answer is found for that question. Any other question on pneumonia, pleural effusion, pneumothorax? Anything on pneumothorax? Okay, if question is based on mild, moderate, severe, it is very simple. You know all the cutoff values. Yeah, Harshit, honeycombing is seen associated with crackles. Generally, if it is ILD, it is not expiratory crackles. We hear inspiratory crackles. And most of the chronic lung disease, we give bacteria, pneumococcal vaccine, and flu vaccine so that the worsening and exacerbation tend to reduce. Okay, I think we can conclude this session, students. Thank you so much for your inputs. It will be definitely very helpful to make sure you will be prepared well for upcoming NEET exam. Okay, then. Thank you so much. All the best and stay consistent. You have come this far putting a lot of efforts. Make sure you end in a very, very positive